through also. So as we go through the day, please, don't hesitate to ask questions because it's important, for us to have a good dialogue in these sessions. It's also important if you're a VA employee, we're always learning and improving also. And your presence here today is a testament to having a good attitude and making sure that we're getting better every day as we learn more and more about gut war illness. I remember, I'm going to digress for a second, I remember being in Indianapolis, Indiana at the VA there many years ago, and they actually started the first gut war registry when I was there back in the 90s. And we're still trying to come to grips with what gut war illness is and what it means and how can we treat it. And so this is a continuing road, and we're really happy that you're here. Also want to mention that, part of this conference is to try to keep up with what the latest evidence-based research is regarding gut war illness and making sure everybody understands what that is and how it might be used. We need all our providers to be their best in order to provide, these innovations that help us learn how to treat this better all the time. And we want to make sure we're giving high quality health care for the treatment of whatever comes from war now and in the future. It's a funny thing, the Persian Gulf War, relatively speaking to many wars that we have, was somewhat brief. But the effects that we've had with it have been long lasting, as this illness has certainly shown us. And what I'd like to say to all of you that are veterans, it's our duty here to follow through and try to keep the promise to try to care for you and give you the best care we can with what we know as we continue to learn about this disease. And I hope everyone learns a lot today. I hope, by collaboration and sharing that we all come away with new information and new ways to think about and look at how we deal with gut war illness. So please be a sponge, soak it all up, offer some to somebody else. And I want to thank you for being here and caring enough to be here, and I hope you all have a great morning. Thank you very much.
Thank you so much, Mr. Battle. Can't think of a better name for a hospital director, by the way, than Joe Battle, right? So our first presenter today is Dr. Peter Rum, and he's the director of the pre-9/11 era program post-deployment health services at the Veterans Health Administration in Washington, D.C. Dr. Rum is a pediatrician, so between he and I on internal medicine, we can cover you from cradle to grave, literally. He's a pediatrician and also preventive medicine physician who came to the VA from the Food and Drug Administration, where he was the Special Projects Officer and the Deputy Clinical Director in pre-market divisions dealing with the regulation and safety of medical devices. He will provide an introduction and an overview of the Gulf War Registry. So please join me in welcoming Dr. Peter Rum.
First off, it's an honor to be. It's an honor to be here. I actually traveled yesterday. It was my 60th birthday and came to Tampa for that and looked at real estate because I'm thinking of retiring down here. So, so anyway, it was a very nice to be in Tampa. It's a beautiful city, and actually having our friends down here, we think a lot of you in the hospital. I want to thank two people. Roger Graves and Shauna Rodriguez for inviting us here and getting this whole conference going. It's been a communication by email and even over the phone with cell phones and text messages to get us down here, and we really appreciate it. Besides being a pediatrician, I'm also trained in preventive medicine. That's really where my background is, and these days do a lot of environmental medicine, and I'm taking the board as environmental occupational health next year, so I'll be potentially border in that as well. But we're going to talk today about what we're going to do today is actually, I'm going to show you a lecture. This is particularly for the physicians. So this lecture already was given credit. It was at the American College of Occupational Environmental Medicine Conference. We presented this in a 90-minute session. So I cut out some slides, but kept most of the content. And I'll actually be giving credit to three other speakers who could not travel, except Erin's here. And part of her slides from the conference will be shown. And by doing this, I think instead of writing a new talk, it's kind of embedded it out there and been used in the conference. And we got a lot of good acclaim on it. And I will say, I'll try and bring some other things into it as I go along and go forward. Let's go to the next slide, please. You all know about about the veteran's charge to care for him who shall have borne for the battle and for his widow and his orphan. And next slide, please. What we're going to do today is a brief review of the first Gulf War, some exposures, introduction to Gulf War illness, also known as chronic multi-symptom illness, introduction to current definitions, and then topics that the other speakers that I'm going to show will cover will include things like the research on the Gulf War illness, Erin's stuff that goes a little bit more into definition and some of the sort of how we define that, and then kind of the most controversial, as I'll show, is by Dr. Ashford, who's a psychiatrist with a PhD in neurosciences. And he has his own theories about what may have caused Gulf War illness, so I'll show some of his slides too. Next slide, please. The Gulf War, as was mentioned, was a fairly short actual war as far as the actual conflict, but with several month buildup. It's called the Persian Gulf War. It has many names. It involved Iraq, Saudi Arabia, Kuwait, Qatar, Bahrain, and Oman. It was the largest in scale since Vietnam. It was going to be the mother of all battles, and about 700,000 U.S. service members were deployed. There's no official figures on the Iraqi military, but estimates are somewhere in 180,000 to 630,000. It's widely varying depending who actually fought. But next slide, please. And when it actually became the conflict itself, the ceasefire was only about 100 hours later, and controversy left Saddam Hussein in power. We all know there was a second conflict because of this. Coalition casualties were in the low hundreds, but especially the United States, but Iraqi losses numbered in the tens of thousands, including both injured and killed. Next slide, please. And it was a massive strike, particularly by the U.S., but with other coalitions. They kind of used the pincer movement to move into Iraq and Kuwait, and it caused, the main thing I want to get out of the slide is that it happened kind of rapidly. And there were exposures, but as the United States kind of stayed in the territory, that's where some of the possible exposures occurred. And some before, we'll talk about some of these in advance, but the preparations may have caused potentially some of the side effects of Gulf War illness. Next slide, please. And the bottom line is Gulf War troops were exposed to multiple exposures despite the short time. The etiology is unclear of the Gulf War illness. I'll just use that term going on. But service members did have multiple possible exposures. And the reason I use that term instead of the chronic multi-symptom illness is actually the Institute of Medicine, which is now called different names, the National Academy of Medicine, Health and Medicine Division, came out with a report that they actually were looking at, this will talk about definitions of Gulf War illness, and they actually prefer the term Gulf War illness over the chronic multi-symptom illness, and that's why I prefer to use it myself. I think it's a little bit more broader term, and it's easier to understand than the chronic multi-symptom illness. Let's go to the next slide. One of the things we're looking at right now is that whether or not there was some of the exposures. There was Tamassia was a chemical weapons dump where about 100,000 troops we know were exposed to low levels of sarin gas after it was demolished. And there's actually been some, as we'll talk later, there's been some studies that have actually shown that not only that showed that there was actually by Dr. Chow showed that there was decrease in hippocampal brain volume in some of the people exposed, and that secondly that there's some evidence that we're taking forward and potentially looking at coverage of brain cancer in people with Gulf War exposures who may have had this sarin gas. There have been several papers, including one by Dr. Barth from our section of the VA that actually showed higher rates of brain cancer in those that were actually exposed to the Tamassia. Next slide. But there were also exposures in many conflicts. There were harsh living conditions, infectious diseases, and some of these were specific to the Gulf. We actually have some presumptions on some of these, such as that, I have to think of some of them, but there were a number of these that were kind of specific to the Gulf War. Other exposures are more specific to the desert scene, with pyrostigmine, anthrax, depleted uranium, and the veterans may report a variety of other exposure concerns, but those are probably some of the bigger ones. Next slide. And these are kind of widespread, that there were chemical and biological weapons. We know that at least the chemical, there was the anthrax vaccine, which is very pyrostigmine bromide, which was given as a prevention for possible exposures. And we do know that there were massive oil well fires, smoke, and petroleum that filled the air right after the conflict. Next slide. Gulf War illness is getting now into the topic of the day. It affects Gulf War veterans, a cluster of medically explained chronic symptoms. VA referred to the symptoms of chronic multi-symptom illness and undiagnosed illnesses. For the, as James Bunker from the National Gulf War Research Center will talk later in the day, to get the coverage, you have to have medically unexplained illness as being the coverage term for what is used for disability compensation in the VA. We don't like the term Gulf War syndrome because it's less accurate, because there's no real syndrome. The symptoms vary widely. And there's still no formal ICD-9 or 10 code for this specifically. Basically, all these things refer to the same thing, and studies have shown somewhere between 20 to 60%. Most of the studies, depending on the definition that's used, around 1/3 of Gulf War veterans at least have some symptoms that could be, continue to have symptoms that could be called Gulf War illness. Next slide. We actually have, as was mentioned by your director, is a Gulf War registry, and this has it's pretty interesting. We have about 30% of those who are, the number is actually higher now, of 190,000, that are actually enrolled in the registry. We actually have a new contract with a team of epidemiologists and experts that are looking at us and trying to make the registry more usable for like research and so forth. But what it does provide right now is basically a history and physical to the veteran where they can get feedback. This cannot be used for a disability exam, but directly, but the information can be used. And so a lot of veterans go through this process and then get the records and go for, if they're trying to file a claim, use that. The Gulf War veterans are also eligible for a new registry, the Airborne Hazards and Open Burn Pit Registry. And a lot of people don't realize that. That's not only for the most recent conflicts in Afghanistan and Iraq, but all our Gulf War veterans can also get an exam and do workup for the pulmonary issues that may occur because of this stuff. All registries, though, the problem, one of the things is we try and use the registry more. They can be problematic because veterans have recall bias, surveillance, and selection bias. These things are there where they kind of self-select to get in the registry. They may have issues recalling the exact history. And then if they're followed over time, if some of these people come back for another exam, the fact that people are being surveilled tends to increase the rate of having illnesses versus a control study. But that being said, we are trying to make this Gulf War, and there have been some papers published on this, but we're going to try and make it more of a expanded use thing and more user-friendly in the near future. Next slide. The other speakers I'm going to talk about will cover things like the symptoms definitions, the controversy of mental versus physical symptom causation, and some cutting-edge research, some of which is controversial. Next slide. I have to give credit to my colleague over here, Dr. Dursa, for coming up with these slides. She's going to talk this afternoon. She's one of our premier epidemiologists and is probably our go-to person on Gulf War illness and brain cancer and other things, topics that kind of relate to that. Next slide. Some of the challenges in defining Gulf War illness is that presents a cluster of medically unexplained symptoms, including fatigue, pain, gastrointestinal disorders, and neurological symptoms, without a clear identifiable medical cause. Several Gulf War deployment exposures have been found to be associated with Gulf War illness, but limited data on dose, duration, and frequent exposure made it impossible to identify one causative agent. And GWI is one of the most pressing health concerns in the 1991 veteran population. Again, about 1/3 of the population has at least some of these symptoms. Next slide. And we're going to talk about the challenges in defining this, because there's been several case definitions. And we actually funded an Institute of Medicine report that came out in 2014, where they actually kind of, I don't want to use, I guess the word is punted it down the road. Instead of coming up with a single case definition, they asked the VA to get to work to define one, and they end up using two that I'll talk about as being recommended, at least in the interim. And the variability in case definitions cause problems because estimates of prevalence vary by definition. Comparisons of Gulfport prevalence across studies are extremely difficult. And not having a single case definition, it just makes the issue more, difficult not only for research but also for clinical care and for disability claims with the VA. Next slide. At the time, there's still no single recommended definition. There's no diagnostic test for Gulfport illness that's specific. This is being looked at. One of the things that's most recently come out is evidence of possible mitochondrial dysfunction. There's been several papers published on that, and there's a lot of move to try and come up with biomarkers of inflammation, or other illnesses that might proceed, that actually have some kind of laboratory test to diagnose this. And this may be kind of something that may come down in the future, and we're keeping abreast with that, and if it comes up, that would be shared widely. Next slide. So we're actually doing this right now. We have a plan in action to actually come up with a case definition. We were actually urged to do so by the government accounting office recently, kind of spurred us, something we were actually looking at in our own realm. But we've got a team of about 17 experts, including Dr. Dursa, and some DOD experts kind of across the agency. What we're doing is we actually have a plan in action where we're going to use, Dr. Dursa and I were actually talking this morning about it. We're looking at potentially contracting out to do very sophisticated modeling, what's called predictive analytics, look at a number of databases to try and come up with a definition. And that's part of it. We'll also be pulling charts and doing a number of other things to try and look at what symptoms are there, using sophisticated tools for that. So we're hopeful that we're right now in the process of getting the plan. The next step will be implementation of this. And the bottom line is that it would be a real step forward for the field if we can actually get there. We're going to give it our best effort. Next slide. So the recommendations of this committee were, again, that I kind of went through it already, but we're to actually have the VA do this. And so we're in the process of doing it. Next slide. Now there actually are two, I mentioned before, there's actually two kind of right now definitions that are used for research, but also been used by some people do clinical. One is called the CDC definition, which is must have one symptom from two of the following domains for 6 months or longer. One is fatigue, mood and cognition, and musculoskeletal. So the bottom line is you have to have this duration, and you also have at least two of the symptom clusters. This definition tends to cause higher rates of Gulfport illness than the next definition. We'll go to the next slide, which is called the Kansas definition, which is a little bit more harder to get in and get all the symptoms to fit, where you must have 3 of 6 domains instead of 2. It includes things like skin symptoms, fatigue and sleep problems, neurological and cognitive. This definition tends to have, when veterans get studying this or studies, tend to have slightly lower rates of the Gulfport illness. Next slide. And the bottom line with the Kansas, it also has a lot of exclusionary criteria. That's one thing that makes it a little harder to get the numbers or the rates as high as with the CDC one. If you have any of these, you're excluded. Next slide. Next slide. The problem still comes down to the physician doing an exam and come up with a history and deciding how to identify this. And in the absence of these gold standard diagnostic tests, it's actually been the history and physical and at least knowledge of these definitions that may help a clinician actually diagnose Gulfport illness. Next slide. And as I mentioned, we're in the final stages of actually getting a plan. And there actually is a definition. It's very small. I don't think you can read it. At the bottom line, several years ago, back in 2014 again, the VA, working with some DoD's experts, came up with a clinical guidelines for Gulf War illness. They came up with what's called the Clinical Practice Guideline, and this basically is a definition, which is basically kind of encompasses both the CDC and the Kansas definition. And this is one of, besides the Kansas and the CDC definition, this is one that we're going to be testing in our plan to go forward to design a case. It actually really pulls in other illnesses such as fibromyalgia and chronic fatigue symptoms as being part of the spectrum as well. And you know, the bottom line is that we think this has some utility. We're going to be encouraging, at least in the interim, that that this be sort of the go-to definition for VA care, at least in the near future, until we get one that's better defined and better formulated. And this, if anybody, by the way, I should probably put this out. My email is pretty easy. It's the only one on the gal. My last name is Rums. It's RUMM, so it's pretty easy to find. If anybody wants a copy of this guideline, just send me an email. I'll send it to you. It's a pretty good review on what Gulf War illness is, and talks about how they kind of derive this definition clinically. And I think of the three definitions, this one has, right now, as good a clinical utility as anyone. Next slide. So, you know, the considerations for refining the case definition will be questions: can a veteran have the Gulf War illness? Can elements such as dose, duration, or frequency and exposure, are they going to be resolved or not? Other symptoms that and features the CDC and Kansas definition do not capture. That's why, again, I think the CPG is a good working model for now. Next slide. So now we're going to move into probably the most controversial thing I'll talk about in the talk. This is Dr. Wes Ashford, is out of California. He is probably not got out of bed yet, but he's a brilliant man who's, again, both a psychiatrist, but also has a PhD in neurosciences. So he's one of the directors of what's called a RISC, which is War-Related Illness and Injury Research Centers. We have three of these. One's in DC, where I'm at. One's in New Jersey. The third one's out in Palo Alto, California, Stanford, near Stanford, where Dr. Ashford actually has an appointment. The bottom line with this is that Dr. Ashford has a kind of a working hypothesis, which we'll get to, on possibly what could be Gulf War illness. And then secondly, he believes that he's come up with at least treatments that may help at least some of the veterans that have it. So we'll go through these slides. Next slide. This is a study he likes to quote that actually shows from the Gulf War what are the rates versus non-Gulf War veterans. And it's important for some of these things like fibromyalgia, depression, sexual discomfort, chronic fatigue, and other things, including asthma. The rates tend to be higher, but it's important to recognize that some of these same illnesses and conditions and or symptoms actually can occur in non-Gulf War veterans. So when we talk about Gulf War, that's important. I think an important point. We talk about Gulf War illness. For non-deployed during the same time, there's at least some rates of illness, depending on the study, which you have to kind of compare the margin of effect between the two to actually get what is. And this was an older study, but a good study showing these symptoms. Next slide. And then this is some data that actually looked at the frequency of symptoms by Murphy, that looked at the percentage of those who were deployed in symptoms and systems. And basically there was fatigue, skin rash, headache, muscle and joint pain are fairly high. And then systems like musculoskeletal and connective tissue, mental disorders, respiratory symptoms, and skin and subcutaneous are also high. But as we had a meeting this week, it's called the Gulf War Research Advisory Committee on Research Advisory Committee on Gulf War Illness, which is a committee that we have by the Secretary. And we had some presentations this week for those who were there that had to deal with, several of the audiences were there, that several of the talks talked about the digestive symptoms, and particularly that mimic those things seen in fairly high rates of things like IBS and other things that can occur at fairly high rates in these veterans. Next slide. And this is a follow-up study that Dr. Dursig brilliantly did. They looked at 30,000 Gulf War veterans, and 44% still reported symptoms consistent with unexplained polysymptom illness. And this is, again, a fairly high rate. And you have things like joint stiffness, gastrointestinal, respiratory concerns, sleep issues. I want to mention the sleep issue. I'm actually involved in doing some research right now. We're getting started looking at sleep apnea. There's some evidence, and we have some internal data that show that for some reason sleep apnea is higher in Gulf War veterans than in other conflicts. Now the reason for that may be confounders like obesity, other medical conditions, and so forth. So we're going to try and sort that out. But sleep disorders, besides sleep apnea, are fairly prevalent in this population. Next slide. And then this is again just kind of view of the symptoms and things that can show up in patients complaining of this. Next slide. And the bottom line is that we have to kind of think broadly of looking at the spectrum of what can be in this illness, because and consider that although we think some are, Dr. Asher used the term somatic medical, I'm not sure that's really totally true, is that even though there may be a psychological condition a part of this, there definitely is also a physiological. And although there are some definite sort of psychiatric and psychological problems, and Dr. Ashford is actually, there's some studies that show things like abnormal brainstem dysfunction and or brain flow issues in some patients with this, and there's some data out there that this may be. And the possible relationship to other illnesses is out there, such as chronic fatigue syndrome, fibromyalgia, multiple chemical sensitivity, and traumatic brain injury, especially from blast. Next slide. And this is at the RISK program, which is in all three centers. They actually looked at the top three symptoms. Now, when patients present to the RISK, these tend to be the most sickest or the ones that have the most symptoms and tend to be referred because of fairly severe symptoms of Gulf War illness or related conditions. And pain is, of all is the highest. It's interesting that it's also seen in the more recent conflicts, like Operation New Dawn and Enduring Freedom. It's also high in those. And they look down the list, things like respiratory difficulty is not as high in the Gulf War illness, but in pre-Gulf War illness. And that kind of goes against some other data that shows that respiratory problems are fairly high in this population. Next slide. All right, this is an important study. In fact, there was just another study published by this Dr. Chow that there is some evidence that some Gulf War veterans have abnormalities in brain volume and so forth, particularly those that were potentially exposed at the Kampuchea. And there was a more recent paper by the same author that came out in 2016 that also showed that this may have occurred. And the bottom line is that Dr. Chow is actually a VA researcher out there in California. Next slide. The fundamental, as Dr. Asher puts out, there's no recognized Gulf War syndrome. There are physiological symptoms, but a physical cause is presumed. There may have been many dozens, but none has yielded acceptable explanation. Next slide. And that he's got 4 or 5 possible, 4 up here that are possible explanations. And the one, 3, the one that he really keys in on, and we'll talk about in the next slide, is possibly this autonomic nervous system disruption. That there's a number of these symptoms that actually occur in other illnesses that seem to relate to that of Gulf War illness. And the bottom line is that, go on to the next slide, is that this thing, and what specifically he thinks may have occurred, is that any acetylcholinesterase inhibitor exposure is a factor he thinks most closely associated with Gulf War illness. And there's one study that put this out, and it was disputed by another group, but the bottom line is there was a lot of exposure was widespread since insecticide, pyrostigmic bromide. And the problem is that the reported symptoms are not totally typical, but there are enough evidence that this could have induced a diffuse anticholinergic state, leading to aberrant cholinergic sprouting of all the symptoms typically reported in Gulf War veterans, particularly chronic pain, chronic fatigue, and GI irritability. So I think Dr. Ashford believes this is a possible explanation for Gulf War illness. Next slide. Now we're going to go into sort of, for the clinicians here, we're going to go into a little bit on treatment strategies. And there actually was an ION report on this in 2013 that gave, the bottom line is that the first step is to identification, and then we've encouraged to bring them into the VA healthcare system. It should be a team approach because the symptoms are so broad. Those of you who have considered for the most severe ones referring to the risk. There's no single therapy to manage the health of veterans. However, there are many effective approaches to reduce symptoms. Next slide. And these include things like chronic, depending on what you're treating or what your signs are, you can use cognitive behavior therapy if you think you have a chronic fatigue-like syndrome. For irritable bowel syndrome, you can use cognitive behavioral therapy again, tricyclic antidepressants, muscle relaxants. And then for post-traumatic stress disorder, which is sometimes a comorbidity, and for there's a number of other things you know, that you can treat with depending on the feedback. I think the bottom line is a lot of this stuff is sort of what has been considered the alternative medicine is besides the medications can be considered. Next slide. Next slide. Is this it? Yeah. And then for chronic fatigue, sleep disorders, gastrointestinal disorders, depression, there's a lot of other treatments that, and again, I can share these slides if anyone wants them that actually has a specific agent. One of the things that, again, is to look at sleep disorders. Again, there's trials going on, as I'll talk about in a little while, looking at things like acupuncture, mind-body approaches, yoga and other things, and CBT to try and treat this. It has been as effective as some of the drug treatments. Next slide. So again, the main thing is pharmacologic is avoid narcotics, but consider antidepressants with anti-pain effects, and there's several of them listed there. Consider cholinergic agents like galantamine. Consider peripheral anticholinergic. And Dr. based on his theory that this is actually the cause of some of the patients with Gulf War illness, Dr. Ashford actually treats some patients with these medicines. And then exercise is a very effective treatment. Again, Dr. Ashford actually practices what he preaches. He's a swimmer. Actually, at his age, he's older, maybe he's Olympic caliber for that age swimmer. And he gets his patients swimming and doing other types of things. New approaches needed for pain control are things like complementary alternative medicine and non-invasive brain stimulation, TMS. With general medicine, when I was at the VA, at the FDA, that was actually the first major medical device that I actually cleared was RTMS after a lot of controversy, but it's now being used for other things besides depression in some trials that may have some effect. Next slide. And then, you know, Dr. Ashford is not a big proponent of medicine, but for some patients, particularly those who have depression, and seem to have these anticholinergic side effects, they'll actually put them on things for the GI agents, anticholinergic agents, doxabine, duloxetine, and other agents. Next slide. And the bottom line is you really need to do a lot of possible referrals. Is you need to at the very bottom, he puts de-emphasize psychological illness, monitor PTSD, depression, and suicide risk. I think this is sort of counterintuitive, but even though Dr. Ashford believes there may be a psychological cause, to treat the veterans, you actually have to get everything else treated first and see if he improves, if he or she improves, and then put therapy as needed for that. Next slide. Now we're going to get into, I think, some very interesting topic, which is what is sort of the research on Gulf War illness. And this is broad and changing almost every day. And these slides were up until early this year in April when we did this presentation. And I'll try and bring up a few that have come out since then. Next slide. This is done by Dr. Kolazinski. Dr. Kolazinski actually was with me in the Army. He was a toxicologist and moved over to the VA. And he's the designated federal officer for this Gulf War Research Advisory Committee on Gulf War illness. They oversee a lot of Gulf War illness, and there's a lot of challenges that when they look at doing this is again multiple exposures, ill-defined, what do you actually put out for, no single therapies, that they're looking at things like symptom treatments, and the bottom line for the research is where do they focus the attention, because they get requests from many grants and stuff, and they have a limited budget. They do the best they can to try and get a lot of this research going. Next slide. And the Office of Research and Development actually sits in the Veterans Health Administration. It's a large, and it funds research across the nation, and VA researchers can apply for this. They also have collaborations with the Department of Defense, but their cooperative studies program is one you're probably most experienced. Those familiar with that actually funds research, like for instance in sleep disorders. There's a Dr. Min who's in Brooklyn at the VA. He's doing studies on sleep apnea. He has a funded grant from the next slide. And when they get the recommendations on what to do, I talked about this Research Advisory Committee on Gulf War illnesses, the National Academy of Medicine, and there's been, which used to be called the Institute of Medicine. In 2016, they came out with a volume that gave recommendations on Gulf War illness and how research and things should be done. In fact, Dr. Dursa, again, was sort of our lead person for our section to help oversee writing a report on that to the Secretary. That's now gone on to Congress. That it gives some things that VA be focusing on. We have a new thing that's completely unrelated to Gulf War illness, but there's been a concern, generational concern from parents who served in not only in Vietnam, the Gulf War, other conflicts, that their children are getting health effects, and potentially even the grandchildren. So based on a congressional law that came out end of last year, VA decided to fund a new study that the National Academy of Medicine is actually doing on generational health effects of serving in the Gulf War as a model for other things. And they're looking at a lot of cutting edge research in genetics and pediatrics and other things, and, to look at whether or not serving in the war actually leads to increased risk, and particularly whether or not paternal transmission can occur. And then the research funding that comes up for this is actually, that does most of the research for Gulf War illness is not only from the Veteran Affairs, but substantially from the Department of Defense. Next slide. This is the internal funding. And the good news you can see is that the research funding is actually increasing. In 2016, there were 12.34 million, which compares to just back in 2012, about 6.72 million. So it's almost doubled. And it went up again for 2017 slightly. The final numbers are not there because there's, depending on what was actually spent. The bottom line is that there's been an increase in funding for Gulf War research. This is been seen as up to the level of the Secretary as being an important thing for VA to get involved with. Next slide. And this is just some evidence of some of the research projects. There's impact to exercise training. There's clinical trials of duloxetine and pregabalin for the treatment of Gulf War illness. Novel interventions. The second one at the bottom is probably one of the most exciting ones. There's some evidence coenzyme Q10, a supplement, can actually have some benefit in some veterans that have Gulf War illness. And this went from a pilot study now to a large randomized placebo-controlled trial, which is undergoing. And then there's some of the more, again, complementary alternative medicine and or psychological, psychiatric treatments. One is mindfulness. It's part of the cognitive behavioral therapy, MALU, that is being done. And so there's a lot of type of research going on that has been funded by the VA. Next slide. And then, as I talked about briefly, the biggest thing, we're really trying to find a biomarker or something that we can actually look at in the laboratory to try and say, this is the diagnosis for Gulf War illness. So there's a lot of or it could be a laboratory blood test, it could be an MRI, it could be something. So there's a lot of things that are looking at this, and also the mechanism of Gulf War illness. So we are. This is the kind of the evolving future, and also looking at things. We have what's called the Million Veterans Program. I don't know if you remember that they're trying to get 1 million veterans to sign up, and they're progressing in that to get large numbers of veterans signing up, where they're actually getting genetic information that may someday help us. Next slide. And then we have more fairly sophisticated called modeling, where they're based in advanced statistical and research designs to actually look at a number of things that could be involved with Gulf War illness. And I think one example is the sleep neurobiology and circuitry, telomerase activity to actually treat that, and the bottom line, there's some of these are animal models, some are human getting to the point of it. They're trying to do human trials on them. Next slide. And there's a lot. These are some recently completed ones. One is RTMS for the treatment of chronic pain, vascular and skeletal muscle function, prevention of hippocampal neurodegeneration due to age and apnea. And a lot of these are the results of these. Many of these will be published in the near future. Next slide. And there's some links there. So again, if somebody wants to get the slides, just email me and we'll get you the slides to look where you can link to a lot of these research things. The two at the bottom are probably the one's called, again, the Research Advisory Committee on Gulf War Veterans Illnesses. That's a very important committee that the Secretary appoints the members to and meets about quarterly. Dr. Dursa and I presented to that in California. And I'm going back to, I did a short presentation this past week on the case definition planning that we're doing right now for them. This is the second time. And we frequently interact with that group. They give a lot of great advice. And then the risk that hopefully many of you are familiar with is the tertiary referral center. If you have a patient with Gulf War illness you think needs some special attention, or you're not sure if that really fits the diagnosis, they do take patients in that for that. They do basically spend almost a full week there and evaluate the patient in a holistic manner and then give feedback to the primary care provider on what needs to be done. Next slide. Well, the bottom line is thank you for your time concerning this topic. It's kind of an enigma why we still have this undefined problem, why we haven't come farther as far as not only in defining it but also in treatment. I can tell you at the VA, I think we're on the front lines of trying to define the illness. There are VA researchers out there trying to do some of the most cutting edge research, and people like Dr. Asher are involved in trying to treat these patients on a daily basis. And he told me personally if anybody had an unusual patient that contact me and we'll contact him, and we can. They also do telephonic consults as well, besides having the patient travel there. So there's ways of getting the therapy to these patients. And the bottom line is we're here to serve veterans. We're trying to do a better job. Thank you. We take a question. Yes. Does anybody have a question?
One of those slides mentioned flea collars. It said something about flea collars as an exposure.
Yeah, there was a lot of biting gnats and fleas and stuff in the Gulf War. So some of the troops actually wore flea collars, and they were exposed to the pesticides that were in the flea collars. It was done. These were not dispensed by the commands, but it worked. The sandflies over there, for instance, are fairly aggressive and so forth. So they would wear these things to try and prevent the exposure. And I think it's permethrin is a primarily agent in those collars. So there was some exposure to those.
I can personally attest that I was for theater, and we were definitely exposed to sarin gas. We saw the mist coming through, and all of our detection kits were going off. They had actually, Saudi Arabia had actually sprayed our area with some of the most terrible DEET. It was internationally supposed to, what do you call it? I'm losing my thought here. Anyway, so it was primarily, before we got up there, they had already sprayed the area to keep the scorpions and all of that stuff down. So our immune systems were already affected by that contamination when the sarin gas came through and made us sick.
Let me just talk, Jim Bunker's here, his president of his organization is a guy named Ron Brown, and Ron is a disabled veteran himself. He has been, we do know there was exposure. There was a plume model that was developed by DOD. The problem is there's some controversy on who, and not saying you weren't, but there's controversy on who exactly was exposed or not. But there's also some evidence that we do know that at least some veterans were exposed, and who and how good that model is. I don't know. Are you going to talk about that, Aaron?
1,000 of us total.
You can talk about that in your talk? Yeah. Dr. Durst is going to talk a little more. She's really more of an expert on that than I am about exactly how the exposures occurred. The bottom line is that I think we can say that we're looking into that for several health problems.
17,000 documents have been
claims go,
classified on it.
as far as claims go, whether or not you're exposed, it doesn't matter. You can't prove one way or another, and your claims is based upon what a doctor has. Veterans can't ascribe their illness to any type of exposure. Veterans are lay people. They can't say my illness is caused by. No doctor can say anything like that. And only research they look at research, and if something like Dr. Dursa's and Dr. Tom's study shows like head migraines are at a much higher rate with blood versus non-blood. The doctor can look at that and then ascribe, well, you've been having migraines since 1998. It's at least likely it's not due to the multiple exposures you have. Not any one exposure. Well, inflammation is one exposure, but you've been exposed to so many as Dr. Rump showed.
Dr. Durst, do you want to comment on that right now? Because she may not be here this afternoon, just on the Condosia, plume, and so forth.
So, yes, so the plume model, there was a joint effort by DOD and CIA in it. They used atmospheric data, they used sort of location data from true, right? And so they identified around 100,000 Army veterans who were under the area. Right. And so those, and there were, days of exposure, 1 day, 2 or more, varying. Those a lot. Right. And I know that there are, and why that's challenging is that to identify somebody under a plume, but there's maybe someone that was 10 feet away from there that saw it. And those, right, and so those people are not under the plume model, but, wind sort of moves, and so, I think that's been challenging because there are people that their true location maybe was they were identified as a plume. Or they were not, but they said, listen, I saw it, I smell it,
Yes, it was very
so I think that that's been challenging, and, again, I think the modeling techniques, 20 years ago, the information, now I think we have better information. So for veterans that are serving in the current, they're much better with the modeling, they know location better. So,
14,000.
yeah. So, and I know that they sent letters out, and I think there's been confusion because they did a first model, and then they did a second model, and then other letters came out. And so, what the General Accountability Office said is that the model that DOD and CIA made, it underestimated the true number of exposed. So, but, I don't think that there's any way to, at this point, they've exhausted all the information that they collected. So could they go back and identify people who, didn't make the cut for the model, but were actually exposed? Well, I
A
think
third of us are growing.
the larger, so, and I'll talk about that in my presentation, but yes, the Comacia issue, and, you know, those were highly toxic, agents, and, I think there's been, I'm not sure if DOD has been as forthcoming in terms of, you know, how much was released, actual doses, and so that, I think that's hard for, you know, researchers now, and even the VA, when, you know, when they have a letter that says you were potentially exposed. That's the language, and
It's not
right, and it wasn't potential, and so.
We'll handle this, I think, in Dr. Durst's talk, so we can get some other questions.
Says my unit was exposed.
I think, for you, ma'am, I think there was a lady over here that had her hand
No
up.
5 years remission.
Somebody else had their hand over there.
Had since then.
I-
For adult life. So that's where I'm.
Yes, ma'am, you're.
I had two questions. One is really the Iowa study where you showed the almost twice the frequency of symptoms in the Gulf War veteran compared to the non-Gulf War veteran. What are the other war theaters that the non-Gulf War veteran that were counted into that Iowa study? Are they comparing them to Vietnam veterans? Are they comparing them to other war? What are they comparing to?
All right, she says she has the answers. I don't know off the top of my head. Go ahead.
Yeah, what happened was in 97, when that was done, there was a veteran out of Clinton, Iowa, that got the Iowa state to do it. So it was Gulf War veterans that were in theater, those that were not in theater, definitely not in theater. And it was done in 97, so it was an early effort, okay? And it, he doesn't have the survey of how many were included. But that was an early effort out of Iowa State, okay? And Tim Striley was the person that worked and got that done. So Iowa State done early, it was published in 97, but it was actually like 94, 95 work and then published.
I think the study she's talking about, what I'll do is, basically, this is during the, I believe the group of this is for the, I believe the comparison group for this one is non-deployed during the same time, but I will verify that. If you email me and get the answer back. You have a second question?
The second question is related to the studies that are being done about family members of veterans. My veteran's sister has fibromyalgia. You know, and fibromyalgia is very enigmatic in itself as a syndrome, but I know that there is some allegation that there's a tie between many of these illnesses that now show up in the family members, whether they're children, spouses, or in his case, he lived with his sister immediately after service for several years, and she is chronically ill with fibro. So I'm curious, I saw, you have a litany of studies being done, but I'm very interested specifically in those studies that are linking not just fibro, but any other symptoms to family members, and how that information can get out, because sadly, these veterans are passing, but their survivors are coping with these same illnesses, and in my case...
What I will do is, we actually have a open meeting with on this meeting next week, and I'm going to see the head named Roberta Wedge, who runs the committee. Just send me an email with your question. I'll refer that to her. I want to make sure they're actually studying that part. I'm not sure if they're doing sibling studies or not, because the committee has not announced their findings yet. But I do know they're looking at children and grandchildren and stuff. It'd be I know spouses has also been brought up.
She'd be like a spouse.
Yeah.
She had to help him because he couldn't live on his own.
I'll refer that to Mrs. Wedge to see if they're studying. I know we got to get time.
The IOM, I think volume 10 has a good bibliography, so go to National Academy of Science, or it's been renamed now, but the National Academy of Science Institute of Medicine, and the last published had in the bibliography studies on children and spouses.
I know the spouse study's been studied. Yes, sir.
I'm a recipient of Desert Storm. I'm one of the ones that went through the oil field and the oil rained down on us. I'm one of the ones that got hit by depleted uranium, I handled depleted uranium, I went through all that. I got just about everything up there. And I'm sitting up here listening to everybody saying study, 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 but the thing about what I'm trying to find out, when soldiers come in and try to explain to doctors the ailment, they go through a litany of exams before they get down to, hold up, how we gonna resolve that problem? I retired 2001. I just got my first shot in my back 2 months ago. When I've been complaining about my back, my pain in my body, I've been going to get shots in my knees, I'm getting shots in my shoulder. Just got my arm cut, from the doctor. All this happened within 2 years, 15 years after 16 years after I retired. And I've been sitting up here asking, and nobody can give me a definitive answer on why we are getting information on this, but nobody can come up and tell us, when we explain to them the symptoms we have, why we can't get no understanding.
First of all, thank you for your service, and it's very noble. And I think you're probably between your question or your statements, you're probably one of those that fits into potentially what's called an unexplained illness. And Mr. Bunker, if you're able to stay around, said he's going to talk about how somebody can actually get evaluated for that and potentially even put in a claim. I think if you have not done that, you probably would benefit from listening to that speaking today, this afternoon.
Yes, but what I'm on the claim, I already put in for that whole list right there. And the first doctor, all he did is looked at me. Didn't even send me through no x-rays. I finally got what they call a primary doctor. That's what they call a primary doctor. I done went through, from the beginning in 2001 here at the hospital before they built to annex on Fletcher. Got a doctor over there, finally got one 2 years ago. 3 months after I had her, she was gone.
So, what can we help you with today? What can we try and
I think, Dr. Brown, I think the answer to this question is we're here educating the doctors about this illness, which will help prevent what's been happening, and that's part of what we're here for. So if we can, that's what we're trying to do, is teach the doctors about this illness, so that this won't happen anymore. That's what the answer to your question.
Yeah, I think that's what you're here for. I had a question over here. I got to take this one, then we'll come back to you. And I probably for time, got to get going. 2 more questions.
My question is, Gulf War illness from the Persian Gulf War. Now, so many decades have gone by, we have that were deployed initially, but they've also had, I've seen up to 20 more deployments, depending on what your branch of service is and what your mission is. So, are you registering all of these people, or just the people that were in Persian Gulf beginning?
We have 2 registries right now, and the one that the Gulf War is just specifically for Gulf War service, the first Gulf War. Again, I mentioned that one of the biggest, the airborne hazards in open burn pit, although it says it kind of ties into lung things, can take anybody from these more recent conflicts, and they do a holistic exam, and they're putting that information to the registry. So I would encourage somebody. The last thing, I should have mentioned this during the talk, but there's a massive effort going underway between DOD and VA to come up with what's called the ILR, Individual Longitudinal Exposure Record. Going forward, troops are going to be tracked for every exposure, they go to every conflict, and there's a pilot program going on this, and we're going to try and get this data in the future going forward for what we should have had in the past. Next question, sir. This will be the last question.
Okay, real quick. When it comes to issues like with my veteran brother over here, one of the biggest problems that we're facing, I've gone to the RAC meetings several times in Washington, D.C. I've been involved in several research projects as a volunteer and so on. Biggest problem that we're facing as veterans suffering from Gulf War illness is that a lot of this information is not being disseminated down to the local level. So, in other words, when it comes to the application of the law, the proper procedure of how to process a GWI claim, That's not hitting the local level.
Yeah, let me just comment on that
No.
real quick. We're doing a lot of education right now. And there's been new education for all the comp and pen physicians have been mandated to have some new training in the past few months that they're doing on Gulf War illness. We are doing webinars, we're doing what's called e-learnings, we're doing a lot of reach out. We're gonna have a conference with all the environmental health coordinators and clinicians. We're gonna be funding them to come for a week in St. Louis in June. There's a lot of things we're trying to do. We need to get better, but we are trying to do a lot to try and educate providers. I think you probably need to turn around.
recommended the Center of Excellence to the Secretary on this.
Yes, sir. Yes, sir. You probably need to